had that awful experience of thinking, oh my goodness, I've been a speaker before and gone to the wrong place, and I didn't want that to happen again. So I reached first David's wonderful assistant, Kate, and then she reached David and we talked. And so David is in the right place, but I owe him. So the reason that I owe him, I translated that into helping him. He's agreed to answer some of your questions at the end of his presentation, but because of what I did to him today and his responding so quickly, I thought I'd give him the answers to the questions. So these are the questions that I think he might have heard today, or perhaps already after delivering 1,000 babies. So the first one sounds pretty easy. How many days are there in a month? Well, each month has an average of 30 or 31 days, except the last month of pregnancy, which has 1,453. The other one I'm sure he hears is, I'm 2 months pregnant now. When will my baby move? And I think David may have said this, with any luck, right after he finishes college. And then the last one that we don't really know the answer to, but because we share positions at the university, his in reproduction, family planning, OB-GYN, mine in healthcare, and particularly infectious disease, we both have wondered what would be different if men got pregnant. The best answer is maternity leave would last for 2 years with full pay, and morning sickness would be the nation's #1 health problem. So the other thing I wanted to share with you about what Dave is talking about today, obviously, both of us in our field see pregnancy a little bit differently. Pregnancy obviously can be a wonderful event. For me, it can be a dangerous one. I've lived through the experience of pregnancy becoming safer, thanks to people like David in the normal course of events, but more dangerous as diseases have emerged, and more recently, even Zika. So I think about it that way. I also have sort of realized after raising a son that raising a child could be expensive. So I thought I'd just share with you that in addition to dangerous and joyful, if you were having a child in 2015, the cost of raising that child to 17 would be $235,000. And I wanted to tell you that excludes college. It also excludes the cost to women for being involved in pregnancy, the cost to their families, and the cost to government. So what David is going to focus on today, among many things that he could because of his expertise, is something about the effect of contraception on expenses and cost. David is an associate professor in the Department of OB-GYN at the university, where he directs the Family Planning Fellowship and Research Program. As I've mentioned, he's delivered over 1,000 babies. He's involved in a wide variety of research projects, including testing new contraceptive methods and improving access to highly effective methods of contraception. He currently leads the program called HER, Highly Effective Reversible Contraception. The county-wide intervention that he's been doing that removed financial barriers to all contraceptive methods has and will provide data on the economic and educational effects of this service for over 4,000 women. Space for expanding contraceptive access for all women with limited resources through Utah. It's my personal pleasure to introduce you today to David Turok.
Thank you very much. It is an absolute pleasure to be here. You all are a fabulous audience for me. As you may guess from my expertise and devotion to family planning, that's a somewhat controversial topic in this state and in this community and nationwide. And you all represent a diverse array of business and community leaders here. You don't have a particular affiliation politically, and you are deeply involved in improvements in the community. And we also, our group, would like to favorably impact 10,000 lives a year, but I'm not going to steal your slogan. I would love to take the bell home as the parent of 3 teenagers to get their attention a little more. That works quite well. Anyway, I just want to spend a few minutes telling you about what we've done. The last time I was here was a few years ago, and I have some exciting results to report in the interim. And I'm hoping to get all of your advice about how we can push this forward and improve access to contraception in this community and make it so that all members of our society have the full ability to reap all of the benefits. So I spent the first, I'm going to say the first half of my career working as a doc at the community health centers here in Salt Lake. I delivered a bunch of babies, helped people get contraception, did whatever OBGYNs do day to day. And it was the service was particularly devoted toward improving access for people who have the greatest barriers to getting healthcare in our community. That's what the community health centers here do. And every day I had a version of this conversation with people. And I would talk with somebody. Many of our patients had not planned their pregnancies at all. And many of them had adverse effects and health problems associated with it or with their newborns. And that's why they came to me. I was the problem pregnancy expert within our group. And every day I would have a conversation that went something like I would discuss contraceptive methods with people and let them know about the most effective methods, IUDs and implants that are also reversible, that can be used for as long as you want, up to 5 or 10 or 12 years. They work as well as sterilization. One of them has this very nice effect, the most common one, the hormonal IUD, to reduce periods. And people would say, oh yeah, that, one of these things, that's what I want. And we struggled mightily at community health centers, and the organization still does, to provide services where people could get that method that they chose. And every day I would do whatever I could to help people get those methods. But every day I had to tell people, like, we can't get it today, and I don't know how long it's going to take. So I'm going to spend the second half of my career devoted toward making that conversation non-existent and providing whatever method people want for birth control so that all of the members of our society have the full access to all of the benefits. And that means women controlling fertility. So there's lots of data to show that increasing access to contraception decreases unintended pregnancy. And unintended pregnancy has lots of negative outcomes associated with it. Women who are not planning their birth are more likely to have a preterm birth. Their baby's more likely to end up in the NICU, less likely to finish school or need additional services at school. And many women face financial barriers in accessing contraception. And I knew at the beginning there were some serious research gaps, and I'll talk more about that. So our solution was the Salt Lake Contraceptive Initiative. And what we sought to do was, for a period of time, to provide any method of contraception to any woman in Salt Lake County. And it basically comes down to this. If you are a woman with limited means in Salt Lake County, you do not get Medicaid. There's very limited coverage if you are not pregnant or immediately postpartum. So if you seek health care, you're essentially paying out of pocket. These most effective methods of contraception, IUDs and implants, are the most expensive also. So people don't have several hundreds of dollars to afford them. And we sought to overcome that barrier. And we built not a war chest, but a peace and justice chest. And we gathered as many resources as we could to be able to provide this service. And we did it at 4 Planned Parenthood clinics in Salt Lake County. And the reason we chose those clinics, and I've worked with a whole bunch of nonprofit healthcare organizations in this community, Planned Parenthood is the most effective at delivering services to the people who can least afford it, period. So if what you want to do is improve access and this kind of contraceptive access, they are the source. They are the place to go to do it. Stretch the buck like pretty much nobody else. So where did we get our resources? We had this collaboration from our group at the university, Planned Parenthood, but we also sought devices, IUDs and implants, because they're costly, from pharmaceutical manufacturers. So we got 3,000 devices from Bayer, from Teva, who make the two most popular IUDs and contraceptive implant. And then we had some research support from the Society of Family Planning and from the Hewlett Foundation. And then we sought a bunch of local support and got that from local foundations, healthcare foundation. And with that, we worked to provide as many women who are going to show up for a year with any method of contraception for free. If they had insurance, their insurance paid for it. If they didn't, we covered it. We did a bunch of things that were different. There had been 3 prior experiments, one in Colorado, one in Iowa, and one in St. Louis called the Choice Project. In all 3 of these situations, women in states where they weren't able to initially get wide access to contraception were able to get it for free, and then they followed outcomes. And what they found in St. Louis, one of the main findings was that women who picked the pill, patch, or ring, common contraceptive method in this country, those women were 20 times more likely to have a pregnancy, an unintended pregnancy, than women who chose the IUD or the implant. So we have really good information based on this large sample of 10,000 women that IUDs and implants are much more effective at preventing pregnancy, and people are much more likely to continue using them. People who pick the pill, less than half of them are still using it at the end of the year. And that is a way, and most of those people are switching to a method that's less effective. While the pill can be effective in a population setting, when 100 couples or 100 women use that over the course of the year, at the end of the year, there'll be 9 pregnancies. When 100 women use the IUD or the implant at the end of the year, 0 or 1 will have a pregnancy. So it's much more effective, and when you roll in the costs of those unintended pregnancies, you end up saving lots. So our project was a little bit different. All of those other states, Iowa, Colorado, and St. Louis, they had one backer. We had lots of backers. And we sought that community backing and engagement. We specifically spoke with folks from the community before we began the project to make sure that we were hitting their targets and that this was something that was desirable for them. And we have a community advisory board, which has been very helpful in moving the project forward. We focused on social outcomes, very much like you all do. We wanted to know, what does increasing access to contraception mean for people regarding educational advancement and economic advancement and sexual satisfaction? We also had a media campaign where we tried to increase awareness by delivering the message to people's handheld devices, which was unique of support. We started collecting data before we did the intervention so we could see what the effect was over time. And we're in it for the long haul. We have access to something called the Utah Population Database, which will allow us to follow people for over 10 years. We've over the course of the year, where we provided free contraception, it was to 7,000 women. We've enrolled 4,400 of them into a prospective study where we will follow them for 3 years and be able to get data on those outcomes that I mentioned, education and economic advancement, and see how people change methods over time and what it means, and be able to generate some real local data on cost savings. So one of the things we did right at the beginning was provide people, we provided training for the 4 clinic sites and made sure that people were being offered all of the methods and allowing them to get the method that they desired. It's not all about the IUD and the implant, but we wanted to make sure that we overcame those barriers so that people would have access when they wanted it. We divided the study into 3 periods: the control period, where it was just care as it had been, and the intervention, where we had free care, and then we also tried to increase traffic by the media campaign in that second intervention period. And what we found was, over time, we've been in contact with over 11,000 women, and that includes, the 7,000 women who got free care, and then the 4,400 women who've enrolled. And at baseline, among the women who had enrolled, we had 20% of people using the IUD and the implant. And that's really good when over 95% of your people do not have insurance. That went up to 44% when we started offering free care. And we've used these data sources, and we'll continue to use them, where we have access to the electronic health record, and as I mentioned, the Utah population database. So we will be able to follow people for a long time and be able to look at things like intergenerational poverty and seeing if this intervention has the ability to break that cycle. So now we're at the point where we can see how far we can take this. We've had a significant achievement. And the last time I was here was in 2014, and it was a pretty memorable day. It was election day. It was 2012. So it was Obama's re-election, and then Colleen Maloof, I think, was the president, and she got up and spoke about what election day means in this country. And she essentially gave a chronologic history, one that I've carried with me since that day and spoken about. And it demonstrates how you gotta continue to move forward over a long period of time. And the picture she painted on election day was that at the beginning, our democracy only offered voting to white male landowners. That was 4% of the population. And there's a graph that can demonstrate the increase. But it was, it hasn't even been 100 years that women in this country have had the right to vote. And we're about half of the population now showing up to vote. So the point of this is a long haul. We're not going to fix a complicated problem like this in a very short period of time. It's going to require showing up day after day over a very long period of time. It's clearly a marathon, not a sprint. So what are we doing now? We're seeking policy change. We want to go beyond just Salt Lake County, and we've been working with the legislature and trying to get increased access through the state Medicaid program. But just that is not enough. We've been raising funds. We have community organizations involved and a bunch of private donors, and have continued to raise funds. And then one of the interesting things that we've been able to do recently was we acquired funding from Sorensen Impact Center at the Eckel School of Business at the University of Utah. And that funding will allow us the ability to work on a Pay for Success program for over the next year and set this up. So are people familiar with that? The way Pay for Success works is you identify an end payer, somebody who will benefit from whatever the public health intervention you're going to deliver is, and then you demonstrate what you anticipate the benefit will be, and then they seek funders for the intervention. So in this case, by preventing unintended pregnancy, we will save the state Medicaid program millions of dollars, and they see the end payer as state Medicaid. And then they will go and seek funds to enable us to provide the services throughout the state and overcome the cost of IUDs and implants and training providers that are not currently familiar with this. And then we'll be able to really expand access. So training providers in other communities is a critical part of this. So over a 4.5-year period, we went from really women in Salt Lake County struggling to get access to methods of highly effective contraception and all methods of contraception and having lots of economic barriers, to a place where now we've provided 7,000 women in Salt Lake County with free methods who might not have otherwise been able to afford them. And we're able to track those outcomes forward and be able to demonstrate the cost effectiveness of that intervention. Our aim for the future is to be able to do this statewide, and we're really hoping the Pay for Success grant will help with that. So I think that this is an opportune certainly our national media is not portraying family planning as the opportunity of 2017. And in Salt Lake and in Utah, we have a unique opportunity to demonstrate that people from a broad array of political persuasions, and social and religious and cultural persuasions, can come together and fight for something that's really significant, because it's about, in the end, the strength of families. And many families will have obstacles to being their best if the timing of their children are not planned. So I view this as a really exceptional opportunity, not just locally, but for us to demonstrate nationally how people can come together to work on a sticky and persistent social problem and get really good outcomes. No-brainer. And it just requires some political and social, just like the Rotary Club, to make it happen. So I'd like to take your questions if I can, and hopefully we can have a little bit more of a conversation. Thanks for your time. I've never been at any kind of presentation that Jay Jacobson didn't have a question about.
Thank you. As a female, I thank you for your work. One of my, and it's my generation, my age, I'm a little older. And so my background is that IUDs were very, very dangerous. Are they still dangerous?
Yeah, that's a fabulous question. So yeah, there was this one kind of IUD called the Dalton Shield that was popular. And at the time, in the 70s, early 80s in the US, 10% of women were using IUDs. And then this thing came along, and there were some other devices at the time. This one particular kind of IUD was bad news. It had essentially a string where there were an interlace of different filaments on the string. The bacteria from the vagina able to get up into the uterus and the tubes, and it caused some really very bad problems for a bunch of people. A small percentage of users, but way too many. And that essentially, because of legal reasons, killed IUD use nearly for almost 3 decades. And what happened was the rest of the world didn't have the Dalton Shield, wasn't really available as widely elsewhere, and it wasn't a commonly used method. The rest of the world continued on and developed new IUDs. The ones that we have now are incredibly safe. Over 150 million women on the planet have used these things. We know they're very effective. As good as getting your tubes tied, but totally reversible. And, excuse me, and then they all have excellent safety records. And the risk of infection now, now there's greater awareness that bacteria cause infection and not the IUD. So yeah, the transition has occurred. And I started talking with my daughter about this at a relatively young age, and now she tells me, when you started talking about this, nobody had one of these things. And now, as she's in the middle of college, and she says, everyone has one now. And what we found over time is our community has always actually had a high uptake of the devices.
I actually have a follow-up if that's okay.
Please.
So the populations that you're attempting to serve with the HER project, which is wonderful, are lower income people who probably don't have a lot of financial means or work multiple jobs or like crazy lives, right? So I'm wondering, it's a 5 to 7 to 12 year IUD that these women can get. And I mean, if they just forget to get it removed or something, like, I'm just wondering what is the impact of that?
Yeah, so that's a fabulous question. These are set it and forget it methods. And that's part of the reason they're so effective. And there are also the things that people, when offered all methods, these are the things that people are most likely to continue. But the essence of the project is not just about IUDs and implants, it's making all methods available, because they're not for everybody. So what happens when people go too long? This is basically the FDA approves these devices for some amount of time. They do not stop working on that day. They are approved for X amount of time, 3 years, 5 years, 10 years for the implant, the hormonal IUD, and the copper IUD initially, because those are the data that are provided to the FDA for them to make a decision. And then what happens is, as my mentor Curtly Jones likes to say, we get to see what happens out in the wild. People use the devices and then they don't come back all the time, or we prospectively follow them closely and say, hey, this thing we know is FDA approved for 3 years. Would you be willing to continue to use it for 4 and 5, and we'll check hormonal levels and make sure that this works. So what we know now is that 3, 5, and 10 really means 5, 7, and 12. And then for those people who do continue, they're still going to work and have some efficacy. The implant and the hormonal IUD, people will notice when they're effective, their periods are, or with the hormonal IUD, they don't have them at all, or they're very, very light. Once you start to have a regular period, it would come back. But even the plastic will decrease pregnancy rates very considerably. There were plain IUDs without any hormones or any copper on them that worked. They just didn't work as well as the ones that we have now. And the copper, we actually have data to show that people have used it out for 20 years. And what happens once you get into longer and longer uses of these things is you get older. And when you get older, you get less fertile. So even if they don't work perfectly, they still work pretty good. So it's up to, people come in and can change. And that's, a really important part of the project that I didn't talk about is that people can come and change whatever and get any method that they want over a 3-year period. So if you were seen in that year of free care, come back as many times as you want over 3 years. Get whatever method you want. You're not obligated to take that thing that you took the first time.
Aside from the financial aspects of it, what do you see as the principal hang-ups on proceeding further, or impediments?
I think the challenges are to really have a greater appreciation among the public that this is the right thing and an intrinsic benefit to anyone who wants to choose whatever method. And the last time I gave this talk to this group, I have this picture of myself sitting on a couch with a newborn and a 2-year-old, who are now 17 and 19. I was a resident post-call, and I think one of our great societal failures is we do practically nothing to prepare people to be really good parents. Like, I've done a whole bunch of what I think are pretty challenging things. I did 2 residencies. I've done a bunch of long endurance athletic things. Nothing is nearly as hard as being a parent. I imagine people are laughing not because they think I'm wrong. And I think really that's one of the big gifts of this project, is to really open up some public conversations about how do we really help people plan for the best health of their families.
You mentioned a financial analysis, and just from the words you've used, it sounds like it would make financial sense, but have you actually put pen to paper?
Oh yeah. No, actually, we put fingers to keyboards, and not me, okay. Real quantitative experts. So, all of this obviously this is not about me, I'm just the messenger. This is a true team effort. It's team science, it's a team of clinical caregivers, it's a team of administrators. It requires a significant effort all the way around. And I think this is our last question. So the bottom line is this. If you are you're a woman in Salt Lake County or in Utah, you do not get coverage for your contraception. And then once you have a pregnancy, we cover 138% of the federal poverty level and lower. So each pregnancy costs the state in maternal care and newborn care for the first year over $12,000. So you don't have to prevent a lot of pregnancies to save an awful lot of money. And if you have more specific questions, I'm happy to talk to you.
That's it.
Thank you very much.
One loaded question from the good doctor. Thanks for anticipating. Studies that you cited, and particularly yours, that are so well designed to find out, what do you know about educational achievement or occupational achievement of women who have this access?
Right. Fabulous question, as always, Dr. Jacobson. We don't know practically anything, and that's why this is such a huge opportunity, because there's really no information on this. There's no, and especially no large data set. But we're really in a unique position as a bunch of egg-headed researchers to make a significant impact. We're hoping and gain awareness for this. Thank you.
Thank you.